Welcome back to the Deep Dive. Today we are tackling a system that is, honestly, a little bit mind-bending when you really stop and think about the engineering behind it. We are diving into the endocrine system.
It is a personal favorite of mine. I mean, it really challenges the way we usually think about anatomy and pathology.
I can absolutely see why. Usually when we're in this space, when we look at Robbins and Cotran, we're talking about a specific organ that's broken in a very mechanical way.
Right, like a pump.
Exactly.
Mm-hmm.
The heart pump fails because the valve is stiff or the lung filter gets clogged up with fluid. But this feels different. This isn't just about static organs sitting there. It's about communication.
Precisely. It's the internet of the body, if you want to get metaphorical about it. But it's an internet built on, wetware, not hardware.
Right. And the stakes are just incredibly high because we're talking about amplification. We're not talking about a muscle pulling a bone, which is a one-to-one thing.
No, not at all.
We are talking about a tiny little gland, maybe the size of a pea, shouting instructions that can change the whole shape of your bones or your mood or how you handle stress or even whether you can reproduce.
That is the perfect way to frame it. The endocrine system is defined by that exact disproportionate impact. You have these small collections of cells, the pituitary, the thyroid, the adrenals. All tiny, and they're releasing these chemical messengers, hormones, into the bloodstream to act on targets that are, they're in a different zip code.
It's long-distance calling.
It is. Yeah. And to really get a handle on the pathology here, which is what we're trying to do, right? We're synthesizing the systems framework of Robbins and Cotran with the mechanistic clarity of Underwood's pathology. We have to start by distinguishing the types of calls being made.
Okay.
Because Underwood makes a really sharp distinction here that just sets up everything else.
Okay, let's unpack that. Because usually cells just talk to their immediate neighbors, don't they?
Right. So you have autocrine signaling. Think of that as talking to yourself. A cell releases a chemical that just acts on its own receptors.
You see that in cancer, right? A tumor telling itself to grow.
All the time. Then you've got paracrine signaling. That's like talking to your neighbor over the fence. It's local. Mm-hmm. A chemical diffuses through the tissue fluid, hits the cell next door, and then it degrades really fast. It's a whisper.
But endocrine signaling is not a whisper.
No, endocrine signaling is a high-gain radio broadcast. A cell in the pituitary gland releases a molecule, like, say, TSH, and that single molecule has to survive the turbulence of the bloodstream, travel maybe a meter down the body.
A meter.
And find a very specific receptor on a single thyroid cell.
And this is where that amplification idea really comes in.
Yeah.
Because the concentration of that hormone in the blood is infinitesimal, isn't it? We're talking picograms.
It's vanishingly small, and that's why the receptor affinity, the stickiness of the receptor, has to be so incredibly high. And this is where the first layer of pathology starts to creep in.
How so?
Well, if you have a system that relies on a tiny, tiny signal to trigger a massive response, like a whisper starting an avalanche, the receiver, the receptor, becomes just as important as the person whispering.
So the disease isn't always the gland is broken. It could be the receiver is jammed.
Or the receiver is just turned on all the time when it shouldn't be. I mean, think about type 2 diabetes. The pancreas is screaming insulin. The signal is loud and clear.
The broadcast is going out.
The broadcast is fine, but the cells have basically put in earplugs. That's resistance. The signal is there. The reception is the pathology.
Now, before we get into the nitty-gritty of all the glands, we should probably issue our standard disclaimer here. We're building a conceptual map. We want to give you the hooks to hang all this information on.
Absolutely. We're synthesizing the best of Robbins and Underwood, but there is absolutely no substitute for actually reading the chapters. Use this discussion to get oriented, so when you look at the text and you see a chart about G protein coupled receptors, it clicks because you understand what the mission of that protein actually is.
Okay, so let's talk about the rules of the road. If the endocrine system is this broadcast network, what keeps it from just screaming constantly? Because if amplification is the name of the game, a little bit of noise could be, disastrous.
The thermostat?
Thermostat, okay.
It's the classic analogy for a reason. The central theme of endocrine physiology, and therefore all of its pathology, is homeostasis maintained by negative feedback loops.
Walk us through that, but give us the biological version, not just the HVAC version.
Right. So in your house, the thermostat monitors the temperature. If it drops, the heater kicks on. Once the temperature hits the target, the thermostat senses that and tells the heater to turn off.
Oh, simple enough.
In the bottle, the hypothalamus and the pituitary gland act as that thermostat. They are constantly sensing the levels of a hormone, let's say thyroid hormone, in the blood.
So they're just constantly tasting the blood, looking for T3 and T4 levels.
Exactly. If the level is low, they send out a stimulating signal, TSH in this case. If the level is high, they shut down that TSH signal. It's a constant dynamic oscillation around a set point.
So pathology then is basically what happens when that loop breaks.
That's it. And in Robbins, they categorize endocrine disease into essentially two main functional buckets. You've got hyperfunction and hypofunction.
Too much or too little?
Correct. Hyperfunction is the heater stuck in the on position.
Mm-hmm.
Maybe you have a tumor that's just pumping out hormone regardless of what the thermostat is saying. Hypofunction is the heater is broken. Or maybe the thermostat sends a signal, but the gland doesn't have the fuel, like iodine, to respond.
But there's a third category that Robbins mentions that isn't about the hormones at all, is it? This is purely structural.
Yes, and this is so crucial, especially when we get into the brain. Mass effects.
The physical problem of just having a lump in a very tight space.
Exactly. The pituitary, for example, it sits in this tiny bony saddle called the sella turcica. There is no room for expansion. None.
It's boxed in.
It's got bone on 3 sides and a tough diaphragm of dura mater on top. So if a tumor grows there, even if it's completely hormonally silent, it physically crushes its neighbors. It can crush the normal pituitary cells, causing them to fail.
Or it can grow upwards.
Right. And if it pushes up through that diaphragm cella, it runs smack into the optic chiasm. This is where the optic nerves from both eyes cross.
Which leads to a very specific, very classic vision problem. Not just blurry vision.
No, it's tunnel vision. Bitemporal hemianopsia. Because of the way the nerve fibers from the periphery of your vision cross right in the middle, pressure there destroys your peripheral vision on both sides. Patients often don't even realize it until they start bumping into door frames.
That's incredible. Okay, so we have the framework. Feedback loops, hyper versus hypo, and mass effects. Let's start at the top. The master conductor, the pituitary gland.
The hypophysis. And it's such a fascinating structure because it's really 2 glands just stuck together. It's a merger.
A merger of what?
Of very different origins. You have the anterior pituitary or the adenohypophysis, which actually comes from the oral cavity embryologically.
From the mouth.
Yeah, it migrates up from the roof of the mouth. It's epithelial tissue. That's the glandular part that makes all the classic hormones we think about.
And the posterior pituitary.
That is the neurohypophysis. And it's basically just an extension of the brain. It grows down from the hypothalamus. It's neural tissue. It doesn't really make hormones so much as it stores and releases what the hypothalamus sends down the wire.
And Robbins describes the control system for that anterior side as a kind of brake and gas system, right?
Yes, especially for the anterior pituitary. The hypothalamus sends down releasing factors. That's the gas. Things like GHRH, which is growth hormone releasing hormone, or TRH, thyrotropin releasing hormone. These travel through a tiny dedicated blood vessel system called the portal system.
But it also sends inhibiting factors, the brakes. And the most famous brake is?
Dopamine. Dopamine is the primary brake for prolactin. This becomes incredibly important for diagnosis later, so, stick a pin in that one.
Okay, pin stuck. Let's talk about when the conductor starts shouting. Hyperpituitarism. Robbins has a new name for these tumors, doesn't it? We used to call them adenomas.
We did, and you'll still hear that constantly on the wards. But the classification in the pathology literature has shifted to pituitary neuroendocrine tumors, or PITNETs.
UPNETs. Why the rebrand? Is this just, semantics?
It actually reflects a much deeper understanding of the biology. We're now classifying them based on the transcription factors that drive the differentiation of the cell. So instead of just looking at them under a microscope and saying, that looks acidophilic or that looks basophilic, which is really just describing what dye they happen to soak up,
right,
we're looking for the genetic driver.
Can you give us an example?
Sure. If you have a tumor that's making growth hormone, it's driven by the transcription factor PAT1. If it's making ACTH, it's driven by TPIT. It's a way of fingerprinting the tumor's origin much more precisely, and that helps predict its behavior.
That's amazing. It's like looking at the factory blueprint to see what the machine was actually built to do. So let's go through the greatest hits of these PITNETs. What's the most common one?
The prolactinoma, the lactotroph PITNET, by far.
This is the one that affects milk production.
Exactly. Prolactin's job is to stimulate lactation. So in women, a tumor here presents as amenorrhea. Their periods stop, and galactorrhea, which is inappropriate milk production.
And in men? What does it do in men?
It's often much more subtle, which is actually dangerous because the tumor can get much bigger before it's found.
Yeah.
In men, it causes loss of libido and erectile dysfunction. But since men don't have a monthly cycle to act as an alarm system, they often present much later with those visual mass effects we just talked about.
Now, here is where it gets really interesting and a little tricky. Robbins talks about something called the stalk effect. This blew my mind a little because it is a perfect diagnostic trap.
It is a critical nuance, and it brings us right back to that dopamine break we just mentioned.
Okay, walk us through it. Because if I see hyperlactin on a blood test and a tumor on an MRI, I'm thinking prolactinoma. Why might I be dead wrong?
Okay, so remember the break. The hypothalamus is constantly dripping dopamine down the pituitary stalk to keep the normal prolactin cells suppressed. It's constantly saying, stop, stop, stop.
Right. Dopamine says, don't make milk.
Exactly. Now imagine you have a tumor in the pituitary, but it's not a prolactinoma. Let's say it's a null cell adenoma. It doesn't make any hormone, but it's big, and it is physically compressing the stalk.
It's pinching the hose.
It is physically blocking the flow of dopamine. The brake line is cut. So the normal prolactin cells, which are sitting downstream and are perfectly healthy, are suddenly released from that inhibition. They look around, see no dopamine, and say, well, guess it's time to work, and they start pumping out prolactin.
So you get high prolactin in the blood and you see a mass on the MRI. It's a perfect mimic.
It's a perfect mimic. And if you treat that patient with a dopamine agonist drug, which is the first-line treatment for a real prolactinoma, it won't shrink the tumor because the tumor isn't made of lactotrophs that respond to dopamine. It's a null cell tumor.
Wow. So how do you tell the difference before you operate?
It's all in the numbers. This is the key takeaway for anyone listening. A true prolactinoma is a factory. It churns out hormone proportional to its size. A macroadenoma, a big tumor, will push prolactin levels into the 2,000, 5,000 nanograms per milliliter.
Okay, so massive, massive numbers.
But the stalk effect, that's just the normal cells working a little bit too hard. They have a biological ceiling. You will almost never see the stalk effect push prolactin over 100, maybe 150 NGML COPS.
That is such a cool piece of clinical detective work. So if the number is, say, 80, but the tumor on the MRI is huge, you have to be suspicious.
You have to be very suspicious. That patient probably needs a neurosurgeon, not a pill.
Okay, next up on the list, growth hormone. This is the stuff of legends, literally.
Somatotroph pit nets. And the outcome here depends entirely on when the excess happens.
Timing is everything.
It is. If the tumor starts pumping out growth hormone in childhood, before the growth plates, the epiphyses in the long bones have fused shut, you get gigantism. The bones just keep lengthening. These are the people who grow to be 7-8 feet tall.
But if it happens in adults, the plates are fused. They can't get longer.
Exactly. The long bones are capped. They can't get longer. So instead, the bones get thicker. This is acromegaly.
Well, this must be a much slower change, right?
Oh, very insidious. Patients often don't notice it for years. Their shoe size goes up by 2 sizes. Their rings stop fitting. Their jaw becomes prominent, what we call prognathism, and their teeth start to separate. The facial features become very coarse.
And Robbins mentions visceral enlargement, too. It's not just the outside, is it?
No, the heart, the liver, the thyroid, everything grows. And metabolically, growth hormone is an anti-insulin hormone. It wants to keep blood sugar high to fuel all that growth. So these patients very often develop secondary diabetes.
Right. Moving on to the stress hormone axis, ACTH.
Corticotroph pit nets. So these tumors pump out ACTH, which then tells the adrenal glands to make cortisol. This leads to Cushing disease.
Okay, just to be super clear on the terminology, Cushing syndrome is the broad term for high cortisol from any cause. But Cushing disease is specifically when it's the pituitary's fault.
Correct. That is a distinction that examiners absolutely love to test.
And what happens if you, say back in the day before we had good pituitary surgery, what happens if you take out the adrenal glands to fix the high cortisol, but you leave that pituitary tumor behind?
You get Nelson syndrome. And this is a fascinating demonstration of a feedback loop in action. You've removed the adrenals, so there is no cortisol being produced to send a negative feedback signal up to the pituitary.
The thermostat never gets the signal that the room is hot.
Right. So the pituitary tumor, which was already aggressive to begin with, suddenly loses its only restraint. It grows very rapidly, and the patient turns. Well, they turn bronze.
Bronze. You mean like a tan?
A deep, deep hyperpigmentation. This is because ACTH is carved out of a massive precursor protein called POMC, pro-opiomelanocortin.
That's a mouthful.
It is. But buried inside that huge POMC protein sequence is another hormone, MSH, or melanocyte-stimulating hormone. So when the pituitary is just churning out massive amounts of this ACTH precursor, it's also spilling MSH. The skin cells think they're being told to darken.
That is incredible. Okay, let's flip the switch. Hypopituitarism, when the signal fades away.
The rule of thumb here is what I call the 75% rule. The pituitary has a lot of reserve capacity. You usually don't see any symptoms until you've lost about 3/4 of the gland parenchyma.
That's a lot of damage before you notice anything is wrong. What causes that kind of destruction?
Well, tumors compressing the normal gland are common. But there is a very specific and kind of tragic scenario called Sheehan syndrome.
This is postpartum necrosis, right?
Yes. And to understand it, you have to understand the physiology of pregnancy. During pregnancy, the pituitary gland actually doubles in size. It's what we call physiological hyperplasia because of the massive demand for hormones to support the pregnancy and prepare for lactation.
So the gland gets bigger. Does the plumbing, the blood supply, upgrade to match?
No, and that's the design flaw. The blood supply, which is a low-pressure venous system, does not increase to match the size of the gland. So you have this big, hungry, metabolically active gland being supplied by a small, low-pressure pipe.
It's teetering on the edge of hypoxia.
Exactly. Then, during delivery, if there is a significant obstetric hemorrhage, a lot of blood loss, the mother's systemic blood pressure plummets. The pituitary, which was already just barely getting enough oxygen, infarcts. It has a stroke.
And what's the very first sign?
Failure of lactation. The new mom can't breastfeed because the lactotrophs, the prolactin cells, are dead. And it's often missed initially because everyone is, understandably, focused on the recovery from the hemorrhage.
That is terrifying.
Yeah.
One last thing on the pituitary before we move on, apoplexy.
Pituitary apoplexy. This is a neurosurgical emergency. It's when a pituitary tumor suddenly bleeds into itself.
Why does it bleed?
Tumors have crappy blood vessels. They're fragile. If one of them bursts, the pressure inside that tiny bone-encased cella turcica skyrockets instantly.
The thunderclap headache.
One of the worst headaches of your life. Sudden vision loss because the optic chiasm gets smashed by the expanding blood clot, and acute collapse of all pituitary hormones. It requires immediate surgery to decompress the area, or the patient can die from an acute adrenal crisis.
Before we leave the head entirely, let's just quickly touch on the posterior pituitary. We said it's neural. What's the main player here?
ADH, antidiuretic hormone, also called vasopressin. Its job is to be the water saver. It goes to the kidney and says, don't pee out this water, put it back into the blood.
So if you don't have it?
You get diabetes insipidus. Diabetes just means to siphon through. Insipidus means tasteless.
As opposed to mellitus, which means sweet, like honey.
Right. In diabetes insipidus, you can't save water. You pour out liters and liters of dilute, tasteless urine every day. You're constantly incredibly thirsty.
And if you have too much ADH.
That's SIADH, the syndrome of inappropriate ADH. You save too much water, your blood becomes dilute, you get hyponatremia, dangerously low sodium.
And Robbins mentions a really specific cause for this that isn't even in the brain, right?
Yes, small cell lung cancer. It's a classic paraneoplastic syndrome. For reasons we don't fully understand, the lung tumor acquires the ability to synthesize and secrete ADH. It's ectopic production.
Again, the wrong signal coming from the wrong place.
Precisely.
All right, let's move down the neck. The metabolic engine. The thyroid gland.
The thyroid is deceptively simple. It basically has 2 gears, fast and slow. But the pathology is just incredibly rich.
So we have the follicular cells making T3 and T4, which of course need iodine. And then we have those parafollicular C cells tucked away in the back.
Right, which make calcitonin. But honestly, in humans, calcitonin is a pretty minor player physiologically. We mostly worry about it as a tumor marker. The main show is T3 and T4.
Let's start with the engine running too fast. Hyperthyroidism, or thyrotoxicosis. And the big one here is Graves' disease.
Graves is the absolute archetype of autoimmune stimulation. Usually when we think of autoimmunity, we think of your body attacking and destroying something. But in Graves, the antibody is an imposter.
It's a mimic.
It's an antibody called TSI, thyroid-stimulating immunoglobulin, and it looks just like TSH to the thyroid's TSH receptor. So it binds to the receptor and just screams, go, and because it's an antibody, it doesn't listen to negative feedback.
So the thermostat, the pituitary, is detecting sky-high thyroid hormone, and it's shouting, stop, I'm turning TSH off. But the antibody is just yelling, go, and the thyroid only listens to the antibody.
Exactly. The TSH will be nearly zero, but the T3 and T4 will be through the roof. And you get this classic triad of symptoms. First, thyrotoxicosis, so racing heart, weight loss despite a huge appetite, heat intolerance. But you also get ophthalmopathy.
And bulging eyes, exophthalmos. Why on earth does that happen? It seems so disconnected from a gland in your neck.
I want to focus on this because it's a perfect example of molecular cross-reactivity. It all comes down to a shared antigen.
Okay, explain that.
The weapon in Graves is that TSI antibody, and it's hunting for the TSH receptor. Obviously, the thyroid is covered in those receptors, but for some cruel evolutionary reason, the fibroblasts, the structural cells that live in the fat pad right behind your eyeball, also express a version of the TSH receptor.
So they're innocent bystanders who just happen to be wearing the enemy's uniform.
Perfectly put. So this antibody drifts into the retroorbital space, finds these fibroblasts and activates them. But fibroblasts don't make thyroid hormone. When they get activated, they do what fibroblasts do. They build matrix.
They start laying down concrete behind the eye.
Specifically, hydrophilic glycosaminoglycans, or GAGs, mostly hyaluronic acid. Now, hyaluronic acid loves water. It pulls fluid into that fat pad with incredible osmotic force.
So the volume of the tissue behind the eye expands.
It swells up and gets inflamed, the muscles get infiltrated and turn fibrotic, and the bony orbit of the eye is a fixed space. It's a cone of bone. If the pressure builds up in the back,
The only place for the eye to go is forward.
precisely.
Yeah.
And the reason treating the thyroid doesn't always fix the eyes is because the antibody is still circulating. Taking out the thyroid gland stops the thyrotoxicosis, but the immune system is still churning out the TSI that attacks the eyes.
That explains so much. And the third part of that triad.
Dermopathy, also called pertibial myxedema. You get this thick, orange peel-looking skin on the shins. Again, it's due to that same mechanism, matrix accumulation and edema in the dermis.
And the worst case scenario here is thyroid storm.
A life-threatening exacerbation. It's usually triggered by stress, like a surgery or an infection in a Graves patient. Massive arrhythmia, super high fever. You have to block the production and conversion of the hormones immediately.
Now let's go to the other side of the coin. Hypothyroidism. The engine is stalling.
The most common cause in the developed world, where we have plenty of iodine in our salt, is Hashimoto thyroiditis.
And this is the opposite of Graves, mechanism-wise, isn't it?
Yes. This is autoimmune destruction. The body loses self-tolerance and sends in cytotoxic CD8 plus T cells to methodically destroy the thyroid machinery.
Robbins has some very specific, very classic descriptions of what this looks like under the microscope.
It does. It describes lymphocytic infiltration with germinal centers. What that means is the thyroid starts to look like a lymph node. It's just packed full of white blood cells, and you see these things called Hurth cells.
That's full cells.
They are these big pink eosinophilic cells. They're metaplastic. They're follicular cells that are changing their type in response to all this stress. They are packed with mitochondria, just trying to survive the assault. It's a hallmark of Hashimoto's.
And clinically, this is the patient who is tired, cold, gaining weight.
Slow. Everything slows down. The gut slows down, so you get constipation. The heart slows down, bradycardia. The mind slows down. And Underwood points out the really important difference between cretinism and myxedema.
Cretinism is the congenital form, right?
Yes. The term is outdated and considered offensive now, but it's still in the textbooks from a historical perspective. It refers to congenital hypothyroidism. If a baby is born without a functioning thyroid, often due to severe iodine deficiency in the mother, they develop profound intellectual disability and short stature. Thyroid hormone is absolutely essential for normal brain development.
Which is why we screen every single newborn for it with a heel prick test.
Exactly. We can prevent it completely with a simple pill. Myxedema is the term for adult onset. The name refers to that boggy, non-pitting edema they get from, again, matrix accumulation in the skin.
Okay, let's talk lumps. Thyroid neoplasms.
This is a very common clinical problem. Thyroid nodules are common. Thyroid cancer, thankfully, is rare.
So how do we tell the difference?
Well, we usually start with an adenoma, which is benign, encapsulated. But there's a really tricky situation when it comes to follicular carcinoma.
Right. Robbins makes a big deal about this. You can't diagnose follicular carcinoma with a fine needle biopsy. Why not?
Because the individual cells look exactly like a benign follicular adenoma, they are just follicular cells. The only difference between benign and malignant is behavior. Does the tumor invade through its capsule? Does it invade into the blood vessels?
And you can't see invasion on a needle suck. You have to take the whole lump out and look at the edge to know for sure.
You do. You need to see the architecture at the edge of the tumor. And unlike most carcinomas that spread through the lymph nodes, follicular carcinoma likes the blood. It spreads hematogenously, to bone, to lungs.
Contrast that with papillary carcinoma.
The most common type of thyroid cancer. And generally it has an excellent prognosis. It spreads via the lymphatics. But the histology is famous.
The Orphan Annie eye nuclei.
Pathologists love their food and pop culture analogies. The nuclei are optically clear. They look empty inside, just like the cartoon character Little Orphan Annie's eyes. It's due to finely dispersed chromatin.
And samoma bodies.
These little concentric calcified spheres, they look like grains of sand or cut onions under the microscope. If you see Orphan Annie eyes and samoma bodies, you are looking at papillary carcinoma.
And finally, the one that comes from those other cells, medullary carcinoma.
Right, derived from the C cells. So it's actually a neuroendocrine tumor. It secretes calcitonin. And because it makes so much protein, specifically procalcitonin, the protein misfolds and deposits as amyloid. So you see amyloid in the stroma of the tumor.
And this one is often genetic, isn't it?
It's the hallmark of the MN2 syndromes. It's associated with RET mutations. But we'll touch on that again when we get to the symphysis.
Right. Okay, let's keep moving down the body. We're at the kidneys now, or rather sitting right on top of them. The adrenal glands.
Stress, salt, and sugar.
I love the mnemonic for the layers of the cortex. GFR, salt, sugar, sex.
It works perfectly. The outer layer, the glomerulosa, makes aldosterone, which handles salt. The middle, the fasciculata, makes cortisol, which handles sugar and stress. And the deep layer, the reticularis, makes androgens for sex.
Let's break down the problems layer by layer, starting with hyperadrenalism.
Okay, so if you have too much cortisol, you have Cushing syndrome.
We talked about the pituitary cause, Cushing disease, but what else causes it?
Honestly, we do. Doctors cause it.
Iatrogenic.
Exogenous steroids, prednisone. It is by far the most common cause of Cushing syndrome. We give steroids for asthma, for lupus, for arthritis. If you give high doses for a long time, you are going to cause Cushing syndrome.
But if it's endogenous, coming from inside the body, besides the pituitary, it could be an adrenal tumor itself, or that ectopic ACTH from a lung cancer we mentioned before.
Right, and the symptoms are so distinct. The central obesity, the moon face, the buffalo hump on the back of the neck.
And those purple stretch marks. The striae,
Yeah.
Why are they purple? Most stretch marks are white.
That's a great mechanism point. Cortisol is catabolic. It breaks down protein to make sugar. It literally dissolves your muscles and your connective tissue. So the collagen in the skin becomes incredibly weak. When the fat accumulates, the skin just tears under the tension. It's not just stretching, it's a full-on rupture of the dermis. The purple color is the blood vessels showing through that thin skin.
Now what about the salt layer? Hyperaldosteronism.
That's Conn syndrome. Too much aldosterone means you keep too much sodium and you lose too much potassium. So you get hypertension from all the salt and water retention, and hypokalemia, low potassium.
And the sex layer. This leads us to one of the most complex topics in Robbins, congenital adrenal hyperplasia, or CAH.
This is a topic that confuses everyone until you visualize a factory.
The factory assembly line analogy is great here.
It fits perfectly. Imagine the adrenal cortex not as a gland, but as a factory with 3 parallel assembly lines.
Lane 1 makes salt, aldosterone. Lane 2 makes sugar, cortisol. Lane 3 makes sex, androgens.
Exactly. And all 3 lanes start with the same raw material, cholesterol. Cholesterol enters the factory and gets passed down the line, being modified by workers who are enzymes at each station.
And the most important worker on the entire factory floor is an enzyme called 21-hydroxylase.
He is the critical bottleneck. 21-hydroxylase works on lane 1, the salt lane, on lane 2, the sugar lane. He is absolutely required to finish the product in those 2 lanes.
So in 21-hydroxylase deficiency, which Robbins says is over 90% of all cases, this worker goes on strike. He's gone.
Total walkout. So what happens? Well, cholesterol keeps arriving at the loading dock. The pituitary sees that there's no cortisol, the finished product, coming out of the shipping day, so it screams at the factory manager, who is ACTH, to make more.
So the factory just ramps up the input. Massive amounts of cholesterol get dumped onto the assembly lines.
But the machines in lane 1 and lane 2 are broken. They can't process it. So the precursors, specifically a molecule called 17-hydroxyprogesterone, start piling up. They're spilling off the conveyor belts.
And there's only one lane that doesn't need that 21-hydroxylase worker.
Lane 3, the androgen lane, the sex lane. It's essentially an open chute, so all that backed up raw material from the salt and sugar lanes gets shoveled sideways into the sex lane.
And you get a massive unregulated flood of testosterone and androgens.
Right. In a male infant, you might not notice immediately. He just looks, well-developed. But in a female infant, that testosterone floods her system while she's still in utero. It changes the architecture of her external genitalia. The clitoris enlarges. The labia confuse.
Leading to ambiguous genitalia at birth. Virilization.
And that's the visual clue. But the real killer isn't the sex hormones. It's what's happening or not happening in lane 1. Remember, that lane is broken too. No 21-hydroxylase means no aldosterone.
And without aldosterone, you cannot hold on to salt.
You pee it all out. You become hyponatremic, hyperkalemic, and you go into hypotensive shock. That's why we screen for this at birth. Because if you miss that salt-wasting crisis in the first couple weeks of life, the baby dies.
That factory analogy really does clear that up.
Yeah.
Now let's flip it again. Adrenocortical insufficiency. When the adrenal fails completely.
Acute failure is a catastrophe. It's called Waterhouse-Friderichsen syndrome.
That's a name.
It's a rapidly progressing condition, usually from meningococcal septicemia, a bacterial infection. The bacteria causes massive clotting and bleeding into both adrenal glands. They basically turn into sacs of blood.
So you go from normal steroid levels to 0 in minutes.
Total circulatory collapse, shock, and death if it's not treated instantly with high-dose steroids and antibiotics.
And chronic failure. Addison disease.
That's usually autoimmune adrenalitis in the West. The cortex is slowly, insidiously destroyed by the immune system.
And here we have the mystery of the tan again.
Yeah.
Why do patients with Addison's look like they've just been on vacation?
It connects right back to that feedback loop we talked about with Nelson syndrome. Low cortisol means the pituitary is screaming ACTH. ACTH comes from that big precursor, POMC.
And POMC contains MSH, the skin darkening hormone.
Exactly. So the high ACTH production essentially dyes the skin. If a patient comes in with low blood pressure, salt craving, and a deep tan, especially in the creases of their hands or on their gums, you have to think about Addison's.
It's a signaling spillover.
Okay,
deep breath. We have one part of the adrenal left, the middle part, the medulla.
the source of adrenaline and the pheochromocytoma.
The 10% tumor.
Pathologists love our rules of thumb. Pheos follow the rule of tens. 10% are bilateral in both glands. 10% are extra-adrenal, which we call paragangliomas. 10% are malignant. And 10% are familial.
And the symptoms are basically a panic attack.
It's episodic hypertension, palpitations, sweating, a pounding headache, a sense of impending doom. The tumor just releases these massive surges of catecholamines. It's like getting mugged by your own adrenal gland.
Vivid and dangerous during surgery, I imagine.
Extremely. If the surgeon just touches the tumor, it can squeeze out a massive bolus of adrenaline, causing a stroke on the table. You have to block the receptors with drugs, alpha blockers, for weeks before you operate.
Okay, let's shift gears to the pancreas. Energy signaling.
Right. Here we're looking at the islets of Langerhans.
Diabetes mellitus. And Robbins calls it a disease of signaling.
It is. It's not just about high sugar. It's about the hormone, insulin.
Type 1 versus type 2. Break it down for us.
Type 1 is silence. It's an autoimmune disease. The body's own immune system destroys the beta cells that make insulin. So no insulin is made. It usually hits in childhood.
And the classic complication is DKA.
Diabetic ketoacidosis. Without any insulin, the body thinks it's starving. It starts breaking down fat for fuel, which creates byproducts called ketones. The blood turns acidic. It's a medical emergency.
Type 2 is different. It's not silence. It's being ignored.
It's insulin resistance. The beta cells are shouting. They're making plenty of insulin, but the tissues, the muscle, the liver aren't listening anymore. The receptors are deaf.
And interestingly, Robbins notes that in type 2, the beta cells eventually just burn out from overwork.
They do. And you see amyloid deposition in the islets. A protein called amylin starts piling up.
Now, why is high shush so bad for you? Why does it cause blindness and kidney failure? I mean, it seems like sugar should just be energy.
Robbins details the mechanisms of damage really well. It's not the sugar just floating by that hurts. It's what the sugar does to proteins. One key mechanism is AG's advanced glycation end products. Sugar basically caramelizes proteins in the vessel walls, making them stiff, leaky, and dysfunctional.
And the sorbitol pathway.
That's the polyol pathway. In tissues that don't need insulin to let glucose in, like the lens of the eye or the nerves, sugar just floods in unregulated when blood sugar is high. The cell tries to deal with this flood by converting it to a sugar alcohol called sorbitol.
But sorbitol gets stuck inside the cell.
It does, and sorbitol is osmotically active. It pulls water in. The cells swell up and die. This is why diabetics get cataracts, from the lens cells swelling, and neuropathy, from the nerve cell swelling.
Hence cataracts and neuropathy.
Exactly.
We also get tumors here. Pancreatic neuroendocrine tumors, or PANENs.
The insulinoma is the classic one, a beta cell tumor that makes too much insulin.
The Whipple triad.
Yes, symptoms of hypoglycemia, like confusion and sweating, documented low blood sugar. And, this is the crucial part, the symptoms get better when you give them sugar.
And the gastronoma.
That's Zollinger-Ellison syndrome. The tumor makes gastrin, which tells the stomach to just make acid, acid, acid. They get massive, intractable peptic ulcers.
Okay, we're in the home stretch now. We need to talk about when the whole blueprint fails.
Yeah.
The multiple endocrine neoplasia, or MN syndromes.
This really brings it all together. These are familial inherited syndromes where you get predictable clusters of tumors in different endocrine glands.
MN1, Römer syndrome.
Remember the 3 Ps? Parathyroid, causing hyperparathyroidism, pancreas with tumors like gastrinomas, and pituitary adenomas.
And MN2, Sippel syndrome.
This one is driven by a mutation in the RET gene, and it's a darker constellation of tumors.
Explain the RET mutation. What is it actually doing?
RET is a proto-oncogene. It codes for a receptor, tyrosine kinase. Usually a receptor like this needs a signal, a ligand, to bind to it to turn it on. But in MEN2, the mutation makes the receptor constitutively active. It's stuck in the on position all the time, even without a signal. It just tells the cell, divide, divide, divide.
And MEN2A.
Medullary thyroid carcinoma, almost a 100% risk. Pheochromocytoma, and parathyroid hyperplasia.
And MEN2B.
Even more aggressive. Medullary thyroid carcinoma, pheochromocytoma, but no parathyroid issues. Instead, they have these mucosal neuromas on their lips and tongue and a marfanoid habitus. They're tall, with long limbs.
There's a really profound clinical point here regarding MEN2 and that RET mutation, isn't there?
Yes.
Anna.
If you identify a child who is carrying the RET mutation, you don't wait. You remove their thyroid prophylactically, often in early childhood before they are 5 years old. Because the risk of developing a lethal medullary thyroid cancer is a certainty.
That is the ultimate example of understanding pathology to prevent a disease before it even starts.
It truly is.
So, bringing this all home, the theme that has run through this entire deep dive has been signaling and amplification.
Think about what we've covered. A tiny clump of cells in the pituitary can change the entire shape of a man's face in acromegaly. An invisible antibody in Graves' disease can drive the heart to exhaustion. A single missing enzyme in the adrenal factory can fundamentally alter the sexual development of a child.
It's the butterfly effect, but inside the human body.
It is. And for the listener, whether you are a medical student or just curious, the key to diagnosing these things is rarely looking at the gland itself first. It's about looking at the system.
Understanding the feedback loop.
Exactly. If the hormone is high, check the thermostat, the TSH, the ACTH. Is the thermostat shouting or is it whispering? That single piece of information tells you where in the circuit the problem is.
I want to leave our listeners with a final provocative thought. We mentioned incidentalomas earlier.
Ah, yes. The curse of modern technology.
Our CT scans and MRIs are so good now, we find these little lumps in the adrenal and thyroid constantly, things we never would have known about 20 years ago.
And the challenge for modern medicine isn't just finding pathology anymore. It's determining if the silence of a non-functional mass is actually hiding something dangerous. Just because a tumor isn't shouting hormones doesn't mean it's not growing or has the potential to become malignant.
The silence can be just as dangerous as a noise.
Precisely.
On that note, we encourage you to crack open Robbins and Underwood. Look at the diagrams of the feedback loops. Look at the histology of the Hurtful cells and the Orphan Annie eyes.
The pictures really do make it all real.
Thanks for diving deep with us. We'll see you next time.